Got something to say? Get in on the conversation at 415-915-2291. That's 415-915-CALL-1.
Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening. Welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. Hope everyone had a happy Halloween. If you have a question or comment for our guest, please call in at 415-915-2291. You can also live chat with me and ask questions or comments on YouTube Live. Our channel is Conspiracies Against Wellness live stream, which you get from our website. Tonight, joining us is guest Dr. Peter Bregman. He is a podiatrist from Las Vegas, originally from Boston, though. He is one of the few surgeons in the country that performs endoscopic tarsal tunnel decompressions. He is also a microsurgeon and can help patients who have had nerve injuries. Dr. Bregman's philosophy is getting the patient back to regular, pain-free activity in the quickest way possible that does not cause pain, using the latest techniques and state-of-the-art technology where appropriate. Dr. Bregman, welcome to Call Nation. How are you this evening?
I am super. I want to thank you for having me on this program. I think it's great that you have an avenue for people who are able to hear information that is not in the mainstream media or promulgated by the drug companies.
Yes, I totally agree, and that's why we are here. Can you please tell me a little bit about yourself and your professional background?
Sure. I moved out here to Las Vegas from Boston, where I did my residency program after growing up in New Jersey, northeast of the United States. And I spent about 15 years in Boston, which was a great experience for me academically, as I was involved in a very good surgical program there. And then continued to teach residents after I graduated. And then after about 15 years, I was offered the chance to come out here to Las Vegas to join a group scenario, which ultimately went by the wayside for a variety of reasons. But I wanted to get out of the ice and the snow. I had enough of that growing up, and I figured I would try to spend some time on the West Coast. So
I hear you.
after coming... after coming out here, I was able to establish myself as a peripheral nerve surgeon specializing in neuropathy, which essentially after my residency program, and I was practicing for a few years, I kept seeing things that didn't make sense to me, and I was confused, or I was misdiagnosing them, and I didn't really understand well enough. And then at some point, I think around 2003, 2004, I received some literature in my mail that talked about learning some new concepts in nerve surgery and diagnostic testing and all these sorts of things related to peripheral neuropathy. And I wound up taking a course with a guy named Lee Dellin, who is also a pioneer in the peripheral nerve industry, who was originally trained as a plastic surgeon and a hand surgeon out of Johns Hopkins. And so I then later joined a group which used to be called, I think, Peripheral Nerve something or other quite a while ago,
Okay.
which that ultimately became the Association of Extremity Nerve Surgeons, which is basically a group of doctors, mostly podiatrists, but also some orthopedic surgeons, hand surgeons, and plastic surgeons, who specialize in peripheral neuropathy and specifically doing surgery on people with peripheral neuropathy issues or injuries. And I became president of that association back in 2010. I continue to be active in the group, and our meeting's coming up next month, which we hold yearly. And we teach other doctors how to do nerve surgery, diagnose nerve problems, and all sorts of good things related to that. So my focus is on peripheral nerve. I do a lot of other surgery as well, reconstructive surgery, flat foot surgery, pediatric surgery. But I think that because neuropathy is so rampant and people don't know enough about it, this is really where my primary focus is.
Okay. So what is podiatry, and what kind of treatments does a podiatrist offer?
Well, that's a good question. It really depends on what part of the world you're in.
Okay.
So if people are listening to us now, depending upon where they are, it's kind of interesting. I belong to several groups in Facebook with different disciplines and different concerns. And where I might tell someone to go see a podiatrist, they say, well, our podiatrist doesn't do any surgery. They just kind of do routine foot care or can't do surgery.
And where is that in the world that it's like that?
Well, that would be in England.
Okay.
Also, sometimes in Canada. There's a term called chiropodists, which is really where my forefathers came from. And chiropodists were doctors who tended to foot problems without doing surgery. Podiatry evolved in the 60s, essentially, where schools were formed that offered residency programs for people who wanted to specialize in foot surgery. And to this day now, we've come really a long way where residency programs now are standardized and often mixed with MDs or DOs, where we have the same exact education, except for we diverge and go into specifically the lower extremity at some point. So we do at least three-year surgical residency now, which I think is plenty for the lower extremity. But in the United States even, different states have different laws as to what a podiatrist can do.
Okay.
One of the things that I'd like to make clear to the audience is that let's just compare a foot and ankle orthopedic surgeon to a podiatrist, at least in today's world. The orthopedic surgeons who are foot and ankle specialists have absolutely no board certification. There's no monitoring of how they are, their training is. They become foot and ankle specialists by virtue of spending a year with another foot and ankle doctor who spent a year with another foot and ankle doctor, and so on. So that's how they become foot and ankle specialists, but there's no governing body that monitors them as far as having a certification. They can be certified in orthopedics, but not certified in foot and ankle surgery, whereas you can be certified as a podiatrist in foot and ankle surgery. And it's important to which board. The American Board of Foot and Ankle Surgery is the only board, really, that I find to be one that's consistent.
Okay.
Oh, one more thing.
Yeah.
I do want to say that each state varies in its law. When I used to practice in Massachusetts, I was unable to perform an ankle fracture repair due to the law, which was really, and again, this is sort of the whole theme of your show, I think, really just came down to lobbyists and the orthopedic surgeons wanted their turf.
Right.
And so they would spend a lot of money saying that we didn't know what we were doing, we didn't have any training, and we're not capable of doing these surgeries. And every year they would just put up a fight, money, and then we would lose. And so our ability to do an ankle fracture, we couldn't do it. Now, here in Nevada, I can do an ankle fracture, no problem. There's no concerns. I don't have anyone breathing down my back. There's a lot of other things. So there's more leeway in certain states than other states.
Right. Wow. Can other people out of state go to another state to get it? Would insurance cover that, or do they make that difficult too?
Yes.
Okay.
It's usually not difficult. I see a frequent amount of out-of-staters, out-of-country patients that usually their insurance will cover it. There's certain things that aren't covered, but most of the time in the United States, if you come from another state, it is covered in most cases.
Okay. So what is neuropathy? I just want to get all these out of the way, and then I really want to get into kind of the meat of stuff.
Sure. So neuropathy is sort of a general term for nerve disease. And you can have disease in your CNS, meaning your central nervous system, or your PNS, or your peripheral nerve system. CNS is stuff like Parkinson's disease, Alzheimer's, Lou Gehrig's disease, things of that nature. The peripheral nerve system is everything outside the CNS, usually dealing with your spine, your arms, or your legs. I don't really deal with CNS. I can identify it. As you well know, the CNS is what gets involved when you're talking about RSD, or complex regional pain syndrome.
Right.
It may start in the peripheral nerve system, but it winds up in the central nervous system. So that neuropathy is sort of a general term for nerve issues, and then it's subdivided into a lot of different categories, which can be inherited or acquired, meaning if it's inherited, you're born with it. It may or may not show itself until later in life, where it's acquired, where you develop it after birth due to some insult or some other issue.
Do you do you work on the whole body, upper body, lower body?
So as a podiatrist, my scope of practice only allows me to deal with from the knee down, not including the knee. So if I have someone who has a peripheral nerve problem that might be in their thigh or their buttock or their back, I have to refer them to someone else.
Okay.
Now, having said that, if someone has neuropathy all over their whole body, they're coming to see me because their feet or legs are the most problematic. Sometimes the treatment that I might do on their legs will also affect the rest of their body.
How does someone get neuropathy? I mean, and what are the causes of it? I mean, you just mentioned you could be born with it. How else? Is it like accidents? Is it, diseases?
So it can be exposure to chemicals. People who get chemotherapy often get neuropathy, which can be transient,
really?
Meaning short-term activity versus permanent. You can have an injury to a nerve. I frequently see people who come in to see me who have a specific damage to the superficial fibular nerve, which is the nerve that's in the leg, more on the outside of the leg. That's misdiagnosed so many times. I actually wrote an article published, I think, about a year and a half ago in the Journal of Foot and Ankle Surgery, which is a peer-reviewed journal, specifically on this nerve, because I've probably done, 400, 500 of the nerve decompressions of that particular nerve. And I would say that I'm probably one of the foremost people in the country who deals with that particular nerve. So that's another avenue. Then there's diabetes, which is really the most common cause of neuropathy in the United States, which is caused by abnormal blood sugar secondary to insulin dysfunction. I'm not going to go into diabetes unless you want me to, but it used to be the most common cause of neuropathy in the world was leprosy, which is no longer the case, but it used to be. Now diabetes has taken that over. And there are a lot of other things, even rheumatological disorders, that can have a side effect of neuropathy. Alcohol can cause neuropathy if it's taken in excess on a consistent basis.
Smoking.
Certain medications cause neuropathy. Even the medications that so-called treat neuropathy cause neuropathy.
What about like Neurontin and Lyrica?
Yeah, those drugs, the side effects of them is actually to cause neuropathy. Now, I'm not saying that
Aren't
they
they
don't have
supposed to
their
help
place.
that?
Well, you have to understand that when I see people with neuropathy, they're usually coming in with one or two or both problems, or three really. Balance problems, because their neuropathy has affected their ability to be able to sense where they are in space and time. Pain, which is the most prevalent reason that they would come in to see me, or loss of sensation, which makes them prone to having infections or other problems because they can't feel their feet. And that's, again, part of the balance issues. So the drugs that you mentioned, Neurontin and Lyrica, and Lyrica is the sister drug
Right,
of
the newer
Neurontin.
one, yeah.
And both of those drugs are primarily used and should only be used to treat significant pain from neuropathy. If they're being used in patients who've been diagnosed with neuropathy, but they're not really having much pain, it's more just sensory issues, then they should not be on those drugs.
Should-
And often, not so much with Lyrica, but Neurontin is often used improperly. It's not
How
dosed.
so?
It's not dosed correctly. I will have patients who frequently come into me who say they have neuropathy, and the doctor put them on Neurontin or gabapentin, and I ask, well, how much are you taking? And very often they'll say, oh, I take 100 milligrams a night or 300 milligrams a day.
That's
and
little.
there have been studies
Isn't
that the therapeutic dosage for pain relief is 1,800 milligrams.
Wow. Okay. Should you be on something like that long term or only short term?
I would prefer to keep someone on them short term. I would never advocate the drugs to be on long term because, again, while we know some of the side effects, we really don't know the long term effects of it, and I don't think the drug companies want you to know those things. So I try, interestingly, I do know that the deleterious and long-term side effects of these medications are probably not good. As I said, they do tend to cause more sensory neuropathy, meaning you'll have loss of it's continuing loss of sensation.
Right.
I use the drug frequently on all my surgical patients because
After surgery?
when you give that drug after, well,
Yeah.
I take it actually the day of surgery and
Okay.
then use it for maybe 2-3 weeks after surgery.
Okay.
And that limits their amount of pain or narcotic usage that they might have after surgery.
Right. My neurosurgeon I've had 5 neck surgeries. He says that afterwards too. Well, he had me do it the same way, the day of and then after for like a few weeks.
Yeah. Yeah, and the protocol is a little different, but I think there's nothing wrong with that.
Also, Neurontin and Lyrica are often prescribed off-label. Do you have any issues with that, or what do you think about that?
No, I don't have issues with off-label usage as long as the doctor is comfortable with it and monitors it.
Okay.
Again, I'm using it off-label when I give it to my surgical patients.
Right.
I mean, it's primarily used for herpes simplex, when you get the pain along the course of the nerve, shingles, and that was its primary usage. Also, I think it was initially also used for seizure disorders.
Right.
But many of the drugs that we treat neuropathy are also seizure disorder based or even depression based. Again, almost every drug that you would use for neuropathy has untoward side effects that very often you'll see people on, as an example, amitriptyline, but they'll be on 2 other drugs to combat the side effects from the amitriptyline.
Okay. I've seen a few articles that also it states that Neurontin and Lyrica can cause dementia or Alzheimer's. Have you heard anything about that, or what do you
I
think
have
about
heard that,
Uh-huh.
and I don't know enough about it scientifically because I'm not a neurologist. But that is again why I try not to put somebody on these drugs long term if possible.
Right.
I think that just like I would treat these drugs not quite the same, but treat them similar to narcotics that you want to just use them short term and try to get people off of it with other means.
So you brought up earlier CRPS RSD, and we have many listeners listening in tonight with this disease, including myself. I went undiagnosed for 6 years and was finally diagnosed in 2015. How do you? I was told you can diagnose CRPS RSD. How do you diagnose a patient with that?
Well, I'm actually shocked that someone did not diagnose you with that for so long.
Yeah, well, I had it since 2009, and then finally I was diagnosed in 2015. And my surgeon, my neurosurgeon, is at Johns Hopkins, and I went to him twice, and then I went to their top neurologist, and they did a whole bunch of studies, and they're like, I think it's your neck, so go back to the neurosurgeon. And I went back to him, and he's like, you're fine. There's nothing wrong with your neck right now. So I moved to North Carolina, and I just happened to go to this doctor, and I was taking notes and journals and photos and stuff like that, and I went in to see her, my first follow up to be in a new area, and she's like, you have RSD, and I'm like, what? I didn't know what it was, and
Right.
she told me to write it down and Google it when I got home. Well, it scared the crap out of me. I mean, I was crying because, you see suicide disease and, worst pain in the world. Freaked me out. But, over time, I kind of accepted it. But yeah, I know a lot of people go undiagnosed for long periods. So how do you, yeah.
It should not be that difficult to diagnose, but I know it can be. And given the fact that I see so much nerve pathology that other doctors miss, I don't think enough attention is paid to nerves in general. So complex regional pain syndrome certainly can be a little insidious and hard to diagnose, but it shouldn't be that hard that you miss it if the patient's telling you things. And just to let your audience know that, there's basically two types of CRIPS, or complex regional pain syndrome. Type 1 is really what you had, I guess, which is RSD.
Well, actually, I think they said type 2.
Okay.
Maybe it was originally that, but...
So,
sorry, go ahead. I didn't mean to...
RSD is the most common form.
Okay.
And it occurs in people who didn't have a direct injury to the nerve itself.
Okay.
So, if you shoot someone with a gun and the bullet goes right through one of the nerves and you immediately start having this pain that's unbearable, that would be a type 2 injury.
Okay.
Now, if you get shot and nothing's sort of going on, and 2 months later you start having this unbearable pain, that might be a type 1 scenario. Or let's say you have even a football injury or a soccer injury where you sprain your ankle, and a few weeks later you start having this crazy pain that's out of proportion to the injury. That would be another indication that you're having type 1 or the RSD types of the CRIPS. So I think there's probably overlap there, but...
Yeah. Well, I broke my neck 2 times. It was 23 years ago, and I've had 5 neck surgeries and stuff like that. So I have a lot of neck issues. And, it was originally in my left arm and hand, then it moved to my right arm and hand, head, mouth, and face. So that's where it's at right now. But also, I don't know, do you know Dr. Getson by chance?
I don't.
Okay. He's from Jersey, and he's one of the top, he came on like 2 months ago. He's one of the top CRPS RSD doctors. He calls it RSD. Everybody calls it different stuff. But he said there's actually type 3, which is, I forget the name of it now, but it's like when you can't diagnose with 1 or 2. So, which I never heard of.
Yeah, and that's why I said there's probably some overlap there, to pigeonhole it into 1 or 2. I don't think that's appropriate because, again, honestly, it really doesn't matter because the treatments for both of them are almost the same. Type 2, where there's a nerve injury, you go ahead and fix that nerve injury.
Right.
And while we're talking about RSD, there's this myth out there that if someone has RSD, you should never operate on them. And that's not true. Mm-hmm. If they have a particular kind of RSD where the nerve is stuck in scar tissue and it's entrapped, you should absolutely do surgery on that. You have nothing to lose. So I just want people to understand that if you're diagnosed with RSD or CRIPS, type 1 or 2, and you go to a specialist like me, and they tell you that you have a nerve that's the source of this pain and they can relieve it, there should be no hesitation to get that done. Right. And but there's a ton of people out there, mostly neurologists, who will say, "Oh no, don't have surgery on that.
It will
get worse."
Right. Yeah, Dr. Getson said you can, and absolutely if it's done correctly. Plus, also he said if you use ketamine when you're under, that will help.
I was going to mention that, but I didn't know if this was the right time. But in patients who have CRIPS, I always attempt, whenever possible, to put them on a ketamine drip even before the surgery starts, and then just continue that through the whole surgery.
Right. Okay. So I said earlier, I started a journal and I took photos of my affected limbs to show my doctors. What would you suggest people can do if they're going undiagnosed? Because it happens so often, and it's frustrating and scary.
Well, again, if you're going to some physician and you're telling them you're having this pain and they don't know what to do, and they're giving you a Advil, Medrol dose pack, whatever, if they can't tell you a diagnosis, they just go, well, I don't know what's going on, but let me give you pain medication. That's not a diagnosis. So you need a diagnosis, right?
Right.
So my recommendations would be to find a pain management specialist, because they're most likely going to be able to diagnose this. I would not rely on a GP, an orthopedic surgeon, most podiatrists, anyone really, other than pain management specialists and neurologists. I would also, we have a website from the group that I mentioned earlier, which is the Association of Extremity Nerve Surgeons, which is www.alpha echo Nancy S, which .us, not .com. You can find people who are in our discipline all over the country. We're not in every state, but you can at least communicate with us. Or if you're concerned, go on a Facebook group for CRIPS, tarsal tunnel, whatever the case may be, and find someone like me who's willing to at least steer you in the right direction.
There are many myths about neuropathy. Can you talk about the different myths and discuss the facts and truth about it?
Well, that's a very sort of broad question.
Yeah.
So
there's the medication that will cure. Neuropathy only affects diabetes. Nerves don't regenerate. Sensations like numbness and tingling.
Okay.
Yeah. Okay.
Okay. So first of all, if you're diabetic and you have neuropathy, medication is, the most important thing is keeping your blood sugar normal, which can reverse your neuropathy if you keep your blood sugar below a certain level. One of the other things also is that something that I mentioned to you previously is that in people who have neuropathy that is caused by a nerve compression, like carpal tunnel syndrome, but it's somewhere else in your body, whether it's your head causing a migraine, your neck causing pain down into your arms, your legs causing pain into your feet, your calf muscles, wherever it might be. Surgery is something that can cure it. So if you're diagnosed with neuropathy and you have constant pain and you get cramping and tingling and moving around, whatever it may be, makes you worse, I would implore you to be seen by a peripheral nerve specialist. And something that didn't exist 5 years ago was a center for that. I was in Boston a couple of years ago, and I noticed for the first time next to Mass General Hospital, there's an actual center for peripheral nerve surgery, which is great. That means it's starting to get the recognition that it needs and deserves. And so I think, people should not rely on their primary care physicians to point them in the right direction if they have neuropathy. It's one of the least amount of, other than depression, dealing with the psychology of depression and psychological issues, neuropathy is probably number 2 in the least amount known on how to deal with it by the medical profession, unless people subspecialize in it, like myself and the people in my group and others. So I think that when you get the biggest myth is if you get diagnosed with it, I'm sorry, nothing can be done for you. You have to resort to drugs, and that's the end of it. That's not true. There are a lot of other things that can be done for you other than taking drugs to help with your situation. And it sickens me when I see this commercial on TV for Lyrica with the pins and needles. I got pins and needles in my feet. Now I take my Lyrica and I can manage my day.
Well, it's just easier, right? Give them a pill.
Yeah.
And they want to make money.
Of course. So it's billions and billions of dollars that drug is making, the pharmaceutical companies. So those are the biggest. From my viewpoint, that's the biggest sort of myth out there is that once you're diagnosed, it's sort of a death sentence for you, and you're either going to take drugs or take narcotics or whatever it may be. But there are many avenues, non-surgical as well, that can be done. One of them is radio frequency treatment, which is applying an electrical field with different frequencies to body parts, which helps promote nerve regeneration and blood flow. And you do that in combination with injections sometimes. And now there's stem cell therapy that's starting to come into play, where research is being done there, and I'm going to be getting involved in that as well.
Good.
So there's a lot more things that can be done other than what people are being shown on TV.
Why is there such a lack of information on neuropathy and the prevention and the treatment?
I think because it's difficult to do studies on people for this, because it's pretty subjective. There's not a lot of objective ways to discern whether one thing works or doesn't. And let me give you a prime example of this. And I had mentioned to you this again before about surgery being something that should be done to diabetics with nerve compression. If you're diabetic and you are diagnosed with a nerve compression in your legs, whether it's one nerve or three nerves or however many, it is now scientifically proven that you should have those nerves operated on, whether or not you have an ulcer or problems with your feet or not, because that will prevent you from having problems down the road.
Okay.
Now, this study came out just this year in 2017. 15 years ago, we knew this inherently. We knew that by operating on people,
who's we?
This group of surgeons that I trained with knew that this was the way to go. Dr. Dellon, who I mentioned before, was really a pioneer in this. And he would go to these meetings at where the American Diabetes Association was, and these prominent neurologists were, and they would say, "You're wrong, Dr. Dellon. This is BS. You're claiming you can cure diabetes with these surgeries," which was not what he was claiming. But they would just throw these falsehoods onto him, and really poo-poo doing surgery on diabetics who had compression. They were really blurring the whole thing. So for 10 or 15 years, all they kept saying was, we need a level 1 study. And for those people who don't understand what that is, a level 1 study is the highest level study that you can do in evidence-based medicine, where basically the doctor and the patients are blinded to what is being done to them. And so in this study that was done, they had one leg where the doctor would go in and do nerve decompression surgery on and do the procedure. And then on the other leg, they would just make incisions and do nothing. And the patient would be placed under general anesthesia. They would make an incision, sew it up, and tell them they had the surgery, no matter what, whether they did or they didn't. The doctor knew once they got in there what they were doing, but they didn't know until that moment where they said, "Okay, doctor, do the surgery," or "No, don't do the surgery." Now, think about how many people would actually want to do that surgery, and you need a good sample size to get that done. And you also need the money to allow that study to be done, because you have to pay these people to get that done. So we as a group tried to get it done, but we never had any money come to us to allow us to do that. But there's one doctor who trained with Dr. Dellon, his name is Dr. Shai Rosen, who is the author of this study. He was able to convince his teaching institution in Texas, I want to do this study, and I want to prove whether or not this works or not. And, so that's an example of why it's so difficult to learn more about neuropathy.
That's awesome. Okay. So this is that the same as with diabetics, the nerve entrapment? Because there's some studies on that. Okay. So does it actually restore sensation and reduce the possibility of amputation? Okay. All right.
Yeah. So if someone is, let's say 35 years old, and they've had diabetes for 10 years, and they're just starting to get some symptoms where they say, "Oh, I'm tingling a little bit. I don't have a lot of pain, but maybe they have a foot deformity." Someone like myself should do a physical exam on them and see if they have nerve entrapment. If they do, my recommendation would be have prophylactic preventative surgery so you don't go on and develop an amputation later in life, because that is a death sentence.
Right. Is neuropathy and peripheral neuropathy the same thing? If they're not?
No.
Okay, what is peripheral neuropathy?
Neuropathy, again, is sort of the general term, whereas peripheral neuropathy means neuropathy in your arms or legs or even your spine.
Gotcha.
So that's delineated again into the different types and whether they're inherited or acquired, or you have there's autonomic neuropathy, which means you have neuropathy of your stomach, your heart, things of that nature. So there's all different kinds of neuropathy.
Okay. What drug therapies are offered for peripheral neuropathy? Are they the same thing as neuropathy?
I'm sorry, what was the question?
Oh, I'm
What
sorry.
therapy?
What drug therapies are offered for peripheral neuropathy? Are they the same as regular neuropathy? Or are they different?
Well, they're probably the same. I think there's probably maybe a dozen drugs on the market that would be used for treating any sort of neuropathy. It might depend on the specific neuropathy, but there's some overlap.
Mm-hmm.
But much like treating depression, where you might try one SSRI over another until someone says, "Yeah, I feel good," and they're not having side effects. It's very similar to treating neuropathy. You can actually use SSRIs, antidepressants, for treating neuropathy. One of them is Effexor, and that drug, if someone's depressed and they have neuropathy, might be a good choice. There's a drug called Topamax, which I use in people who have neuropathy and have difficulty sleeping because it can really help you sleep. Some of the older drugs, amitriptyline and disipramine, those were primarily used for depression. We use them for neuropathy. Disipramine is a good drug. It doesn't have a ton of side effects. Then, of course, the ones we mentioned earlier, gabapentin, Neurontin versus pregabalin or Lyrica. And the only difference between Lyrica and gabapentin or Neurontin is the dosing. If someone can't take 12 pills a day, then Lyrica is only typically twice a day.
Right.
And the side effects may be a little bit less, but there's really not much difference in what they actually do.
Yeah, my doctor put me on Effexor, and then they moved me to Cymbalta. And honestly, personally for me, Cymbalta, I didn't like that. I was on it for a long time, and years. And then I felt like more depressed on it because I wasn't depressed, but it was for my pain. That's what they wanted to see if it would work for pain, and I didn't really notice the difference. So when I went off of it, it was really hard to go off of. It was like bad side effects, but that was me. I've heard other people that had a good experience with it and they like it. So, do all of them?
Yeah,
do you have to step off all of them? That's one thing I've learned. I asked my doctors, do I have to step off of it? Because if I do, I don't want to be on it, unless if it's like, something I really need.
Yeah, most of the drugs you do have to step off of to some degree, especially Neurontin, gabapentin. Because usually they're taking, when patients go on Neurontin from me, until, if it's what I call long-term, meaning more than 2 months, I put them on a dosing regimen. I hand them a piece of paper that basically says, you're going to start at 300 milligrams, and you're going to take this for 3 days. And then if you don't feel any relief, which most people would not, every once in a while I get someone who does, but then I say, okay, now you're going to take 600 milligrams, then 900 milligrams, and so on, all the way up to 3,000 milligrams or 3,200 milligrams. If they're not getting relief at that point, then they have to wean themselves off and go backwards. The same as with any of the drugs. Disipramine, I would do the same thing. I'll start people on a dosage maybe at 40 milligrams and then work their way up to 100 milligrams. And then you just have to be aware of the cardiac effects of that drug and maybe do an EKG on that patient every 3 months or test their cardiac enzymes, whatever you need to do. But by and large, if someone's on a drug for, let's say, more than a week or so, I do want them to try to wean off if possible.
Yeah. What other ways can people help themselves when they have neuropathy? Like with diet and stuff like that?
Sure. So a lot of neuropathy is inflammation-based. And inflammation really is the root of all evil in our body. And the prime mover, if you will, in neuropathy is sugar. Sugar causes the most inflammation in our body, other than being exposed to some kind of chemical or something of that nature. But sugar is the root of all evil. So if you can eliminate sugar from your diet 100% for the most part, that will go a long way at helping your neuropathy. And obviously, not consuming alcohol on a regular basis, having one or two glasses of wine every day, that's not going to do anything for contributing to your neuropathy. Eating a good diet where you're maintaining your antioxidant level is important. One of the things that I do in my office, which I started doing about a year and a half ago, I have this little device in my office. It's called a biphotonic scanner. And what it is, it's a device that works off of Raman spectroscopy. and the patient puts their hand on this device, and in about 30 seconds after it performs a scan, which is completely painless, it spits out a number. That number correlates with your antioxidant level in your body.
Cool.
It actually measures the carotenoids in your skin. Carotenoids is sort of a general way of looking at the antioxidant level in your body. And the higher your antioxidant level in your body, the less inflammation you should have. So people who have chronic diseases, they're smokers, they're going to have really low numbers. People who eat really healthy and exercise a lot, they're going to have really high numbers. And so I will scan people in my office, especially if I'm going to operate on them, and see where they lie. And if they're not doing well, we have to try to make changes to their diet, changes to their activity levels when possible, so that they're going to have the best outcome. So eliminating sugar, making sure you have a good diet, taking supplements if needed. There are vitamins such as and supplements, alpha lipoic acid, benfotiamine, vitamin D3. These are metabolites and nutritional supplements that augment and help your nervous system. So these are all things that someone can do when they have neuropathy. And obviously, if they're being exposed to something that's causing neuropathy at work or whatever the case may be, that will be helpful. And then also, if someone's had chronic neuropathy, more than 5 years, and they've been dealing with pain, they've been on drugs and pain clinics, I highly recommend whenever possible that they see a psychiatrist or at least a counselor to help them deal with the issues, because they feel helpless and lost, and nobody knows what they're going through because they're not going through it.
Right.
And even going to support groups can be helpful.
Yeah, because I've had this for 23 years, and it's different diseases and chronic pain and chronic health issues, and a year and a half ago, I changed my diet, and I started eating foods with inflammation and antioxidants, and then I started a regular workout program of what I could do. Sometimes I can't do it all, but I would do what I could, even if I just move around. And then I started stretching exercises, breathing techniques, meditation, and then along with like some natural stuff like essential oils and stuff like that, and like plant-based supplements. And then with the medicine, I was actually able to go into remission for a few months with CRPS, which was awesome. And it was a lot to do with because of all this combination of stuff. And, I was able to go off my medicine, which is the first time in like 16 years. So, but, it's not a definite thing, or it's not something I can keep up always. So, but as soon as I start not misbehaving and not eating right and, just letting it go, I fall apart again. But you're right. It's very hard to talk with people that don't understand when they're healthy, especially if you have an indivisible disease. Because a lot of people that, I'm friends with online, they do. So people don't understand. And if they see you, they think everything's fine. I think it's a good idea, like you suggested, to see a therapist. I did, and it really helped me. It really did. So those are good suggestions. What is your stance on medical marijuana?
So, being in Las Vegas here, we had medical marijuana here for a few years already, and we just went recreational this past July. And I'm a huge proponent of medical marijuana. I think that there is this moral high ground that our current government here in the United States is sitting on with the Attorney General, who doesn't know what he's doing or talking about and targeting the wrong people. Medical marijuana is so much better than any other drug for treating chronic pain, including neuropathy, due to the lack of side effects that are, the side effects from marijuana when it's, you're getting a good grade of the product is temporary for the most part, and as long as it's not being abused like any other drug. And the benefits far outweigh any of the little bit of side effects that one might have. And so it is really hypocritical to say that it's okay to have alcohol legal and fine when we have all these groups of AA and all this drunk driving and people are making a big stink about marijuana. And so what's going to happen is the drug companies at some point are going to figure out how to get into this business. And once that happens, it will explode.
Right.
I don't know how exactly it's going to happen. It'll be interesting to see what happens in this country over the next 10 years. But as far as using it, I suggest to my patients constantly to get off whatever drugs they're on and try medical marijuana, whether it's topically, using high CBD, very little THC if it's needed.
Is that legal everywhere?
And,
the CBD?
Is what legal?
The CBD oil, or is that considered like because some states you're not allowed to, yeah.
CBD, you can take CBD, and as long as it's pure CBD, there's no issues with it. You can buy it without anything. You can buy it online. But if it has any THC in it at all, then it becomes you either need a card for it, or if it's not recreational in your state, then you can't buy it. I think you just have to be careful out there and make sure you're getting really good product, because I'm sure everybody and their mother is trying to produce whatever, and you just want to make sure you're getting it from a reputable source. The biggest concern from my patients when I suggest it to them typically is, it's interesting, there's a dichotomy of patients where my older patients, and when I say older, I mean around 70-ish, they always kind of say to me, I was thinking of going to marijuana. I used to smoke it when back in the Woodstock days and everything. And so they don't really have any issues with it.
Right.
Whereas people who are, let's say, in their 40s or somewhere around there, they might say, well, my job, I'm worried about my job.
Right,
if I get tested, I'll lose my job. And I'm thinking,
Well, I have a question for you.
So it's okay to... Go ahead.
So there's this girl that I was speaking with. She just got her green card. She's in, I forget. I think Montana. Anyway, she was taking off her opiates, and she has a lot of health issues. And she got the green card, and I'm like, why aren't you going to get anything, because it will really help you. And she said she's afraid, she doesn't know what to get. She's afraid it will hurt her in some way. And she's probably listening in tonight. So what can you say to her about, if she goes in? I told her they will explain it all, because my sister lives in Colorado, and, she uses it. What can she do? I mean, because she's so nervous about getting them. And this isn't about a job, because she's disabled.
Well, yeah, it's not uncommon for people to be uneducated about the process, and that's normal. If I was going to go start race car driving, even though I have some experience in that area, I would still have fears about doing that because I don't have any knowledge of it. But so you have to just lose the fear and go to a reputable place that has a good reputation, and they will help you. You say, listen, I don't know anything about this. Here's my medical issues. I'm looking for pain relief. I don't really need to get high. And they'll offer you typically something that has predominantly CBD in it and maybe a little bit of THC, because hybrids tend to give you a little more relief than just using CBD. Now, if someone wants to just try CBD by itself first and hope that works, that's great. But if it's not, don't be discouraged, and don't think that if you start taking the THC hybrid version that all of a sudden you're going to become some kind of pothead and you're going to be addicted to marijuana.
Right.
It's not true. And even if it was, I'd much rather have you on marijuana for 10 years than on narcotics that are destroying your liver.
Right.
And having a lot of other side effects. And, obviously right now in this country, there's a big push to curtail and curb the use of narcotics by everybody. In fact, in Nevada here, and having a lot of other side effects. In about 2 months, and I think in January, there's going to be a new law that basically says anyone who's writing narcotics for any patients has to go through all this paperwork, just like I was a pain management specialist, where we have to have you sign a form that says you're not going to get it from anyone else, and we're going to test your urine and all this other stuff. Right. So there's going to be some big changes coming. But and I want to make sure I discuss this before, if about one of the other treatments for neuropathy, which is kind of exciting and still, again, on the early upslope here, in the early cusp, is radio frequency treatment, which not too many people know about. There are clinics on the country. Some of them are run ethically, some of them are not. and and I'm not going to name the names of these companies necessarily, but there's there's this radio frequency treatment that you apply basically pads that are hooked up to electrodes at certain frequencies, and you run them on the patient for about half hour, 45 minutes.
Like a TENS unit, almost.
That cause. I'm sorry.
Like a TENS unit, kind of, or.
Okay. Yeah, it's the same theory. It's kind of like a TENS unit, but think of it as if I were to say a TENS unit was a Volkswagen Beetle from 1970, and what I'm talking about is a Ferrari from 2017.
Okay, gotcha.
Okay. Different technology, totally different, more powerful, much more effective than a TENS unit. TENS units will not cure or regenerate tissue, whereas this type of technology will.
So how do we find out about this stuff? Because I'm sure tons of people want to know.
Yeah, you probably have to just Google electrical frequency treatment for neuropathy, and you'll find somebody close to you who's doing it.
Okay.
It's generally not covered by insurance, and can cost anywhere from $2,000 on up to $7,000 for a year of treatment.
Wow. But honestly, if you get your health, if you get your health back, there's no price on that. So.
Yep. No question.
What do you think about? Oh, go ahead. I'm sorry.
I was just going to say, I'm hoping that at some point I get involved in using this treatment and then kind of bringing it synergistically with stem cell therapy and maybe some other types of biologic therapy, and trying to see if that's a really good match to give people the maximum results.
Well,
that'll be hopefully in about a year or two. I'll have an answer to that.
Awesome. Well, when you do, you're going to have to come back on and tell us all about it.
Of course.
So you just mentioned stem cell injections or stem cell therapy, which I've had. They did it about a year and a half ago, above and below my last fusions in my neck, and it seems to have helped my neck and my CRPS. What do you think about stem cell injections to help neuropathy and other health issues?
So, as I mentioned earlier, it's very difficult to get evidence level 1 or level 2 evidence-based medicine. And so, based on everything I've seen personally and heard from colleagues, I think it's a huge positive that we don't know enough about yet. And what's nice, though, is there's really nothing negative that can happen to it unless someone really screws up. So whenever I have patients who they're at their wits' end, they've tried everything, and I say, okay, well, now we can offer you stem cell therapy, whether it's intravenously or injections like you had, where you're injecting the target, or both, where you're injecting intravenously and the target.
Right.
I just tell them, unfortunately, the worst thing that can happen is you're going to lose a fair amount of money.
Yeah.
But you're not going to get hurt, and you're not going to cause any damage.
Well,
if they've already done everything else,
go ahead.
I was going to say, if you've done everything else and nothing's worked, and you're in pain every day, if you have the means to do that, I think that's probably the way to go.
I mean, I didn't have a lot of money at the time, but I used carecredit.com, and as long as you paid off in a year, you don't have to do anything. But yeah, that's what I used, and it was so worth it, because I used to have constant sharp pain, like a knife going in my neck, and I don't anymore. And I changed a lot of things in my life, but I mean, it happened within about a month or two afterwards. So they wanted me to get 3 of them.
And I'm glad,
go ahead.
I'm really glad to hear that story from you.
Yeah.
And I know what you were about to say is they wanted you to get another injection.
Yeah, they wanted me to get 2 more, and I didn't.
Yeah.
I didn't have the money.
And, yeah. I mean,
if it starts bothering again, I'll do it.
Right. Yeah. No. I think, and the thing is, if you, to do a study on this, again, like a level 1 study, like I mentioned, you'd have to have people with the same sort of problem, and you're treating it, if you came in with your neck and Crips, and another person came in with diabetic neuropathy, and you're treating with the stem cell, and one gets better, one doesn't, you learn nothing. So I don't know if we'll ever get to the point where we have enough information, but I do believe that it is certainly an avenue that people should investigate, especially if they have to figure out a way to financially get them, because I think everyone listening, especially on the show, has been in chronic pain, and there's nothing worse. Nothing. People who suffer from migraines, they're the worst. And so if there's a way, an avenue to possibly, get rid of that or at least keep it under control, unfortunately, don't depend on your insurance companies. I want everyone to understand insurance companies are never, ever, ever your friend. They never care about you, and all they want to do is make money.
I was just going to ask more about that.
Aetna and United Healthcare made close to $1 billion this year each. So there's something wrong with that.
Absolutely. Hey, we have a question from YouTube Live. Stacy Fields says, I'd like to know about HGH injections for failing organs, human growth hormone. Could it help pain like pancreatitis? I have read it can regenerate organs. It's NTO, really not on topic.
Okay. So it really is not on my topic, and I'm not an endocrinologist, and I know very little about HGH. So I can't really answer that question. I wish I could, but it's not in my realm.
Okay. So you just mentioned there are a lot of problems concerning health insurance companies, especially allowing patients to get the correct treatments and medications. Can you please talk more about this? Because I think people need to hear it.
Sure. So whenever I have patients in my office, I always tell them that it's me, you, and your insurance company in the room. You may not see them, but they're in here. Mm-hmm. And so I know what's best for you as the patient, but your insurance company is going to tell me what you can do. And something that's very disturbing to me, I understand it, but it's still disturbing. And it really is more a millennial thing than anything else, but it's not solely to millennials. If a patient comes in and their insurance doesn't cover it, no matter what it is, they tell me, I don't want it. I don't care what it is. If my insurance doesn't pay for it, I'm not getting it done. Even something I had a patient come in who had an ankle fracture, and they initially got diagnosed with an ankle fracture. I had no X-rays, and I told them, I said, I don't know if you need surgery or not, because I need an X-ray to determine that. How much is the X-ray? It's going to be, your copay on your insurance is $40, which again is another, I don't want to lose my train of thought here, but insurance is every year, without fail, make the person who bought the insurance policy, everybody out here listening, pay more on their copays and more for everything. Why? Because they want to make their money they're making every year. So every year something gets taken away and they have to pay more for other stuff. So I honestly don't know why people even have insurance anymore. They just keep their money, and when they go to a doctor, say, I need this done, here's my cash. Obviously there's going to be people who need care if they're really sick. Right. But by and large, if you take that money you're spending on insurance, put it in an account that's accruing interest, and just don't touch it until you need it, I think you'll actually do better in most cases, and you'll take better care of yourself.
Yeah.
If
there's healthy people, I definitely think that. Oh, sorry.
Yeah. To get back to that girl, she walked out of my office because she didn't want to pay the $40 for me to diagnose her.
Wow.
And that to me, it's just crazy. And I have all the time, at least once a month, I get on the phone with a doctor from an insurance company, and it's usually the same person who's going to tell me exactly the same thing. I know there's a procedure that I can do surgically on this patient that works great, and I've done it on other people with other insurances, no problem. But this particular insurance says we're not going to pay for that. Why? Because they found one study somewhere that said the success rate is not that great, and therefore, we think you shouldn't be doing this. Mm-hmm. Yet there's 10 other studies that say it's good, but as long as they can hang their hat on one study that says this doesn't work, we're not going to pay for it. And, I have patients who had a procedure done on one side of their body when they were paying for it, and now they're coming back for the other side, and I have to tell them, well, you have to pay cash now because your insurance said no longer, they're not going to pay for it anymore.
So my stepdad has prostate cancer, and he found out recently, and he's worked at a factory for, 20 some years. I mean, just hard worker, everything. Anyway, he lives near Philly. So he was going to a doctor, first they wouldn't do the testing for him. His insurance wouldn't allow it. Then they said, oh, well, you could get surgery after the new year, so in 2018. They went to another doctor, and I don't know how they did it, but they are able to get it in December. What's going on there? I mean, why is it okay for certain treatments and then it isn't for others? I don't get it.
It's hard to listen. I always tell people, if you're trying to think logically and appropriately about insurance companies, you're fooling yourself.
Gotcha.
There are things they do. I'll give you a prime example. As a foot surgeon, I do foot surgery, and I give out what's called durable medical equipment products. Mm-hmm. I'm going to give you two examples of something that drives me bananas. I will do a surgery, and the insurance company, and I'll go in, I'll spend my hour and a half doing the surgery, use all this equipment, I do my thing, and then I have to see the patient essentially for free, which is okay for 3 months. And during that time, they come in for their post-op appointments, and we give them bandages and stuff that we can't charge for, and take X-rays, etc. I might get paid about $400 for that, maybe $500, of which 50% is gone, and then tax it. So in the end, it's like a couple $100 to do a bunion surgery, which is crazy. Mm-hmm. And if I give them a boot to wear after the surgery, to walk around in, I'm sure people have seen people wearing these boots, mm-hmm. Get paid $400 for the boot, and that costs me $30.
But for the surgery, wow.
Yes.
And
here's one more thing.
Sure.
I'm sorry.
No, go for it.
One more thing that's crazy is if people have bunions, let's say bunions, which is a deformity on the feet, on both feet, mm-hmm. the insurance company, if I do both at the same time, meaning I'll operate on one side and do the other side right back to back, so it takes about 3-4 hours, depending upon the surgery, they only pay me half the amount for the second foot.
Wow.
I'm in there longer, working harder, probably, debilitating myself as far as my neck and my arms and my muscles.
Right.
Longer. But they're only going to pay me 50% of what I got paid on the first one.
So it's like a 2-for-1.
Which makes zero sense, because if most doctors won't even do it anymore because of that. But if I don't do it that way, and I say, well, we'll do your first surgery here, and then the next one 6 months later.
Right.
That's 2 times they have to pay the fee for the hospital, and the anesthesia and everything doubles.
Right, so you don't want.
So you would think they would actually pay you twice as more,
right?
But they don't. That's crazy.
That is crazy, and there's a lot of people that have this thing, and if you don't want to answer, it's fine. But so do you have drug companies, like the people coming in and trying to give you medications and stuff? A lot of people think that you make money off the backs of the medications that they buy. And well, I want to know, because people really ask this all the time, and I have you in here, and I know you're gonna you're awesome. So but they're thinking that, and I think they blame the doctors a lot, and it's not the doctors so much, it's the drug companies, and it's the everything else, the medical institutions and stuff like that. What do you think about that?
I think back about 15, 20 years ago, and that may have been true, where they would send the representatives from the drug companies in the office, and typically they were very attractive women for the most part.
Right.
And they would drop off their drugs.
Somebody said they looked like porn stars.
Well, I don't know about that. I don't think I
heard that.
When I was in Massachusetts time when that was going on, maybe in Vegas they were sending porn stars, but not
sending them, but they looked like them.
I understand.
Yeah.
So maybe in Florida and Vegas and wherever else, but not in Boston. So they would come in, and they take you out to the really nice dinner where they might spend $150, a couple $100 on you. And even before me, I don't know this, but I heard stories of people taking them on $5,000 trips, and buying them golf clubs and all kinds of crazy stuff. That doesn't exist anymore. The government has made it so difficult. Ironically, they are a bunch of hypocrites because of their lobbyists and how much money they get thrown at them. We can't even get a pen from people anymore. It's ridiculous. So now when these people come in my office, honestly, here's what happens. They show up, they drop off some samples, they make you sign a little pad, and then they go on their way. Occasionally, they might bring in a lunch for the staff that costs, nowhere extravagant. It's like, $40-50 for the office. They bring it in, they say hi, and then they leave. That's the extent. So it's highly unlikely at this day and age that doctors are being swayed by drug companies. Now, I'm not saying that maybe some of these really expensive drugs that maybe rheumatologists use or cancer doctors use, that stuff doesn't happen, where there's some sort of shifty stuff going on. It's probably not very much. It's probably a small percentage, and it probably does exist. But by and large, that practice of doctors getting money from drug companies doesn't really happen anymore.
Okay. Last Thursday, President Trump declared a public emergency on the opioid crisis. And I also heard he's looking for a drug czar. I know there are a lot of addicts that need help, but like they are bunching addicts with chronic pain patients. And I believe this is wrong. What do you think about the opioid crisis?
So I think there is one. And I think part of the blame of that is that we didn't have marijuana legalized in this country for so long. But and I think there will be overlap. I think that people who have been on opiates for a long time and are physically and psychologically addicted to them need the proper help and channels to move them to a different direction or help them out in any way they can. I think attacking the illegal use of opioids, the black market, if you will, hopefully is the way they're going to go, and they're not going to go after doctors who are practicing ethically and trying to help their patients with chronic pain. And, these people who are making these laws and going after people probably are people who were never on narcotics for any length of time because they weren't having chronic pain. They don't understand it. Yeah. So, I don't know what's going to happen. I just hope that they do it right, but it's the government, so it probably won't get done right.
Yeah. Well, I've been working with several doctors and a lot of advocates, and we're trying to get out the truth and facts and not myths and fear. I don't know if you know Dr. Thomas Klein. He lives in Raleigh. He's retired, but he is really big on the opioid crisis or epidemic, and he's trying to help out chronic pain patients because the thing is people are dying right now because it's not so much that I think there was pill mills and stuff like that, but I think a lot of those are just gone now because it's almost impossible to do that. But I think also a lot of doctors are afraid to prescribe anything, and they're afraid of the DEA and CDC or whoever. Well, first they're afraid of getting their license taken away, but there's just a lot of fear there. I didn't realize this, but there is this drug czar. Did you know this? Aslinger, for 32 years. He was under 5 presidents, and there hasn't been one since. After he was gone, I think it was in 1962. He was from 1930 to 1962. But he actually kind of was the one that created the fear of, so if you are on narcotics, you are a sex fiend or a sexual predator, drug addict, thief, whatever. And it kind of picked up from there, at least, this is from what I've read. I'm just concerned about I understand about that the addicts have problems and they need help. But I'm just trying to say, it would be nice if somebody like myself, who's a chronic pain patient, that can have the opportunity to be able to have the best quality of life if I need that. I mean, I've had this for 23 years. It's not like it, I broke my foot and then, a few months later I'm okay. And I understand that, but what do you think about all that? And what do you think about changing the narrative? Do you have an idea of how to do it, or are you just not into that?
Well, let me give you an example of a patient of mine who I had, not here, but he was a guy very well respected in the community, probably now about 55 years old, had a motorcycle injury when he was in his 20s. Where it shattered his foot and had a lot of problems with it and was placed on narcotics to give him pain relief. And I wound up seeing him, late 40s, early 50s, and he was taking approximately 30 to 40 Percocet a day of 10.0s.
Wow. And
he was completely functional. You would never know in a million years that he was on narcotics chronically.
Right.
And he would call me from God knows where and in withdrawal crisis because he took too many. So,
how did he take too many? I don't understand.
Well, there are certain people who can take that many and
right.
need it, whether it's physiological, whatever, and they can be fine. But what I told him is, listen, And he was taking Percocet. So I said, if you're going to do this, you better at least, and by the way, he was also
Well, the Tylenol is bad.
substituting.
Yeah.
Yeah, exactly.
That's what I'm worried
about.
about.
You got to get off the Tylenol at least.
Right.
So, and also he would lie to me and tell me these stories about someone broke into his car, and I would say to him, listen, don't bullshit me. You don't need to bullshit me. If you ate too many and you screwed up, you tell me, and don't make up this BS. And and he would lie to his wife about things, and it was just it was like a whole. He just, that was his normal. And from the outside, though, I'm like, there's no way your wife doesn't know based upon everything I know. She just doesn't tell you or thinks it's okay. And again, maybe it was okay because, again, he was fully functional, never had any problems, never got in car accidents, and never did anything out of the ordinary. You would never know. So for people like that, that's okay. If that's what, and he would say, listen, and I actually got him off that medication for a while. I got him off it for about 6 months. I made him go see a specialist. They detoxed him, and he was off it for 6 months. And he came to me one day and said, Pete, I've decided that my life is not better when I'm not on medication. That medication, I get through life. I feel better. I'm going back on it. Right. That's just the decision I made. And that's okay. He can make that decision as long as he's functional, not hurting people. And so to get to your root of your question is, there has to be an avenue where evaluations can be done on certain people where you say, okay, you know what? You're a contributor to society. You're doing well. You're functioning, and you're being monitored, so that you're not getting it illegally. And so, I think that's the most important thing, that it's monitored. People's health is being monitored, and there's no form of illegal ways for them to get this stuff.
Well, I heard last
whether that's possible.
Yeah.
Or not.
Yeah. I just think some states are getting really bad about it, or areas. Because I had a candlelight vigil a few weeks ago for a woman. Her husband passed, and because he was on narcotics, they took him off. He had brain surgery. He had all these surgeries. I mean, really, it was somebody that actually should be on pain medicine, and without it, he had no life. And he was one of those people that functioned perfectly fine on it. And the doctors took him off. He was miserable. He ended up killing himself. And I've met so many people in the last few weeks, same stories, and I just don't understand why these are real people with real problems and real chronic pain issues. It's not like, they don't get high from it. I mean, I don't get high from it, because of my pain, which, I didn't realize, but it's because of, I guess, dopamine and whatever, how it is, but it just doesn't happen. It's just really sad that that's happening. And then not only that, when your pain is out of control for long periods, you could get other things, like high blood pressure, the cancers, other illnesses and stuff like that you're going to end up dying from if it's not controlled. I'm just frustrated for my community.
It is frustrating to me, and unfortunately, you have Big Brother, the government, who's now making it a national. There was always this sort of underpinning. The DEA would send out these letters. And, you get things about from the pharmacy. This guy's, drug shopping. Maybe you shouldn't worry, and blah, blah, blah.
And that's the thing now. Pharmacies and health insurance is all involved. It's all they're working together.
Yeah. Yeah. Oh, yeah. No. They absolutely are working together. The health insurance lobby is now the biggest lobby in the world. Yep. It used to be the oil companies. That's no longer true. It's the health insurance companies. They have the biggest lobbies. So believe me, it's all a scam, and that's why I always have this conversation with patients all the time. But it's very easy, if it needed to be done, to have a proper healthcare system. The problem is nobody wants to have a proper healthcare system that's in the government or in the insurance companies, because there's so much corruption and deceit and grifting going on at the levels higher, with between the lobbyists, the people in government, and the companies themselves, that we will never ever have an insurance scenario that's fair and appropriate until you take the corruption out of it, and that's never going to happen.
Yeah. So you mentioned earlier you were previously the president of the Association of Extremity Nerve Surgeons. You are also big on social media, and we discussed many of the problems and issues doctors and patients are facing. What are you personally trying to change, and how are you doing that?
Well, again, in my particular profession, I think that people are not being educated on certain subjects by their own doctors, other doctors in my specialty or in my realm of my specialty.
Is it the doctors that don't know? Where's that? Okay.
That's correct. So, in other words, my specialized training in nerves is very specific. And so probably, and I say this to my patients all the time, and I don't say it to build myself up. It's just true. If they were in any other doctors in the office in Nevada except one other person, they would not be diagnosed correctly, and they might get lost. What happens is people have these nerve problems in their legs, and I'm not talking about complex regional pain syndrome. I'm just talking about general nerve injuries or nerve entrapment, whether they're diabetic or not. And most of the ones I see are not diabetic, ranging from anywhere from 16 years old up to 90 years old. They go to someone else besides me, and they don't know what's wrong with them because they can't diagnose it. So they get diagnosed as having tendonitis or spinal problems or whatever it might be. And eventually they wind up in a pain doctor's office. Now that pain doctor is going to do this with their algorithm. We're going to do injections into your back. We're going to see if you get better. We'll do EMG and CD studies. We'll order MRI.
Are they doing that for the money? What is that for? Why are they doing all that stuff?
There's going to be a certain amount of people who do it for money, and there's also going to be a certain amount of people who do it because they just don't know any better, and that's just what they were taught. I'm going to do all these things, and I'm going to try to figure out what you got. And, the problem is, if you take an MRI of 100 people just walking randomly on the road, 50 of them are going to show they have a herniated disc.
Right.
Of those 50, only 10 really need treatment, maybe even less.
Right. Yeah.
So, there it is. There's your problem. And then now you're treated for this for 10 years, and that was really never the source of your problem. I see patients all the time who have
you could live with a herniated disc. It's not like it's going to kill you. You know what I mean?
Absolutely.
Yeah, because people are like, oh, my doctor said I should get surgery. I'm like, no. Unless if you are like almost paralyzed, don't do it, because then it's going to make you're going to have to get more. Yeah.
No, I would avoid back surgery at all costs. But there's a condition in the leg, which is an entrapment of the common fibular nerve, which is at the level of the knee, which is very commonly entrapped. And I've seen a fair amount of patients, more than 20 in the last couple of years, who have been told they need knee surgery or back surgery, and the problem was that nerve. Right. So a simple 20-minute outpatient surgery on that nerve would save them a ton. I had a patient who was about to get reconstructive surgery that was going to screw them up royally. And fortunately, they came to see me because that doctor who was going to do it was out. And I wound up doing this nerve decompression, and the patient did just fine. And that was a 20-minute surgery. So that's my biggest thing, and the reason I'm on social media is to get the word out that when you have these problems and doctors are not diagnosing them, challenge your doctor. If it sounds like it's a nerve problem, don't waste your time with someone who doesn't know how to deal with them. Find someone who does, if you can. That's why I'm on social media. I think part of it also is just my personality, that I enjoy doing that kind of stuff. It's rewarding. And if I help one person in India or wherever, I have, it's much to my surprise, I have no one doing my YouTube site except me. I do all the videos. I edit them all. Usually when I'm lecturing somewhere, I'll make it happen on the plane ride wherever I'm going and try to do it. I went from having like 10,000 views to now 170,000 views, and 2 followers to 270
that's
followers,
awesome.
and that's great. That's not really what my goal was, but it's just to educate people and make sure that get the word out. And one of the biggest things that I have a problem with, and our group does, not just me, is that there's this entity called Morton's neuroma. And Morton's neuroma is a condition where there's a nerve entrapment in the foot, pinched nerve, if you will. And the treatment of choice by 90% of all doctors in the world is to cut that nerve out. Cut it and just do it. there's no reason to do that. Nerve decompression surgery works great. It works better than cutting the nerve out, where you just simply cut a ligament above the nerve, and people do wonderfully with that. But there's so many, especially in other parts of the world, they just cut it out. And there's something called a stump neuroma, which basically happens when you cut the nerve and it grows back. The little nerve ending fibers find some bad tissue, and they latch onto it and cause severe chronic pain. And I have that on my YouTube site as well. Patients who've had it where they were just, I literally had one woman who I saw from Arizona came to me, and she had a post-traumatic stress disorder from having her nerve cut out.
Wow.
And so, my goal is to have people stop cutting the nerve out and just decompress it. Because let's say you decompress the nerve and it doesn't work. I barely have ever seen that, but when it doesn't work, then you can go in and cut it out. You didn't burn any bridges.
Well, what do you think about for CRPS patients? Because I've heard some CRPS patients, their doctor said, "Oh, if you get this nerve moved or something like that, it will take it away."
Well, yeah, that's true.
Okay. Oh, it is. Okay, because I didn't realize that. How?
Yeah, if someone came to me and I diagnosed them, and they came to me with Crips, and I found the nerve that was causing it, and I would find that by injecting a local anesthetic into it, and if they said, "Oh, wow, I feel a lot better," my pain's still there because it's in the central nervous system, but I feel better, then I would either go in and find that branch of that nerve, as long as it wasn't controlling any motor nerves, your muscles or your gait, and I would cut it and bury it into muscle. Or if it was an injury where there was a lot of scar tissue and it was never addressed, I would just go in and try to decompress that nerve. It also depends on the timing of it all. Now, if it's 10 years old, I might be more apt to cut the nerve or do something else. And there are a lot of other surgeons who are far more skilled than I am, who are microsurgery trained out the wazoo, and they do it every day in and out. And sometimes there's things that I can't do, and I'll say, you know what, you need to go see someone else if possible. And that becomes the frustrating part for me, because there's no one here who can really do that. There's a couple people. But for some really sophisticated stuff, they might have to go to Texas or Chicago, and people just can't do that.
Okay. If people want to join and advocate, with what you're doing, how do they do that? Is there a website?
Lay people or doctors?
I'm sorry, say that again.
You mean doctors or just
no, the everyday regular people, our listeners. If they want to be able to kind of be a part of what you're doing.
Well, I think that they should maybe hop on our website, the one I mentioned earlier, the www.aens.us, and there's avenues there to donate, even $5, and get on the list or follow us. I believe we have a Facebook page. If you look us up on Facebook, I'm pretty sure we have a Facebook page. You can join my YouTube site and ask questions.
What's your YouTube site?
Those are all. I think it's just, if you look me up, it's Dr. Bregman, Peter Bregman, DPM.
Okay.
I think if you just look up Peter Bregman, DPM, you'll see my YouTube site. And if there's, the biggest thing that we need to do is be able to eventually publish. The only way we're really going to get to know and really get the word out is to have someone who's going to give us a lot of money, and we're talking, millions of dollars, to do the research that we need to do to get it out there.
Okay.
And once we do that, that's going to be helpful. Now, I realize that's not the norm, and it may not happen, but just keeping people informed that, hey, there's doctors out there who specialize in this stuff, and you should not be relying on if you get that feeling your doctor doesn't really know what's going on and just kind of guessing, get out,
walk away,
and find someone else.
Yeah, I learned that a long time ago. Is there anything else you'd like to share with us tonight?
Whew.
Do we miss
anything? I think I covered pretty much everything that I thought was important.
Yeah.
And again, I appreciate the time of the people who listen, and I'm always available to answer questions if people have some concerns. My email address is doc, Bregman, my last name, just like the third baseman with the Houston Astros, docbregman@gmail.com.
Okay.
And
very
often I get emails from people asking questions, and I'm happy to answer them.
Okay, cool. So a little off topic here. I heard you like science fiction, and you're a creative writer. What kind of things do you write?
Well, I don't have much time to write anymore, but I've written actually a long time ago when I used to watch Seinfeld. I wrote an episode of Seinfeld.
Love Seinfeld.
And Uh, I
Wait,
did
you
not.
wrote it. You wrote an episode that aired.
Well, that's what I was getting to.
Okay.
So I actually called them up and said, "Do you guys accept scripts?" And they said, "No, we don't." They said, "If you want to send it, go ahead and send it, but we're not using outside writers." So I sent it anyway because I wrote it, and I'm like, "Well, it's not going to do me any good sitting here." So after writing it, within the next year, I believe, somewhere around there, three of the main things that I wrote in that one episode were all in episodes on Seinfeld, almost verbatim.
That is so awesome.
so, so I have that to at least acknowledge that. And then I've written some science fiction stuff and some epic stuff that's still, and another comedy about texting. You know, I was sort of wanting to write a comedy movie about the social dumbing down of America, especially the younger generation, where you know, I frequently will be out to dinner, and you'll see people sitting at a table. They don't say a word to each other; they're just busy texting. And I wanted to make a commentary on that, so I wrote a movie about this couple. They don't say a word through the whole movie, so it's like an hour-long movie, and they never talk to each other. It's all texting. Everything's done through texting. Even when they go to the McDonald's to get some food, they're texting and using their text-to-voice to order their food, and there's a whole bunch of crazy stuff, and you know,
Well,
crazy
maybe
stuff like that.
you know,
but yeah,
we're going to be launching a network here. Maybe you'll want to come on and do it on here. Have your own show.
Maybe. Well,
Just
we'll
thought.
see if I can fit it into my schedule. But one last funny story is
Sure.
I also do impressions
Yes,
of
please,
many
tell
people.
me.
And
Can we hear a few?
I got to meet the guy who really taught me, or at least I grew up and I learned to do impressions by watching Rich Little.
Okay.
And I actually wound up meeting Rich Little about 3 years ago. I was actually at one of my nerve meetings. We were actually holding here in Las Vegas. And it was about 9 o'clock at night, and this woman who was a patient of mine had invited me to go to Rich Little's house. I had no idea. You know, it was for just because it was about a movie I was writing. And she said, "Oh, come to this party, Rich Little's house. You'll meet some people, blah, blah, blah." And so I went and met Rich Little, and, you know, this woman brought me down into the basement, and Rich Little was holding court doing something, and all of a sudden she just pulls me right in the middle.
Thank you.
Says, "Hey, Rich,
Okay.
this is Dr. Bregman. He's here to, you know, he does impressions, and he says yours, I don't everything." "Oh, that's wonderful. Come on up here. Let's see what you got." And so I did some impressions for him, and, you know, it was very nice. I got a nice little ovation from all the people in there, but it was really cool. That was a surreal thing that I'll never forget.
Do you have any like voice impersonations that you'd want to do for us?
Well, I guess I can do, I will do someone, okay, so let's see if you can guess who this is. And
Okay.
I think this was Canadian, actually, originally.
Okay.
"Hey, Rocky, watch me pull a rabbit out of my head here."
Oh man. Brian, do you know that? What is it? Oh, Bullwinkle. Okay. All right. Gotcha. All right. That was I knew the voice, but I just didn't know. I couldn't place it.
You ever watch this TV show Taxi?
Yes. Although, you know, that's a little bit old for me. Sorry.
Oh, okay.
I'm a little younger than that.
But you've seen the movie Back to the Future, right?
Oh, of course.
Yeah. So you know Dr. Emmett Brown, right?
Right. Oh, is it the same guy in there? Okay.
Same guy,
Okay.
Christopher Lloyd.
Okay.
So Christopher Lloyd, you know, kind of talks like this. "Marty, listen, I'm going to take the car out later, and we're going to go, and we're going to gigawatts. Everything's going to be great."
That is awesome. Yeah. That sounds so good.
Yeah, my patients, when they read my bio, will say, "Hey, Doc, I see you do impressions."
Yeah.
Well, you know, and I go, "Yeah, who do you want me to do?" And they often don't even know, or they'll say someone I don't do. And then I just wind up doing somebody, and I'll say, you know, like, "Don't worry, Arnold is here to help you. We make our way back to the chopper. Everybody go in.
Yeah.
Well, now, let's go." So,
Arnold. I got that one. That is so awesome.
that's good. Thank you.
Well, you know, Dr. Bregman, it's been so wonderful to have you on this evening. Thank you for sharing like all your knowledge, and thank you for all the amazing advocacy work you do for chronic pain patients, communities, and other health communities. again, if people want to contact you or check out your published writings in scientific journals or listen to any of your international lectures, how can they do that one more time?
I think the best way probably is just Google me, honestly. When you Google anybody, you'll find everything they've done, and you'll see my YouTube page if you want to look at that specifically. And if you want to email me specifically, you're welcome to do that at docbregman@gmail.com.
Awesome. Yeah, I'm putting that out for everybody else. That's awesome. I hope you will want to come back sometime and possibly come on have a show. That would be really awesome. You could do your impressions.
Well, we'll see. I'll work on a bit. I'll see what I can do and come up with some things.
Maybe when you retire.
And actually, it's interesting. My father, who may eventually listen to this, if he's not listening now, he probably isn't. But he once told me not too long ago, he said, Peter, you should actually embody your impression, because when you do your, as an example, when you do your Christopher Walken.
Oh, would you do that? I love him.
I will do it.
Okay, good.
But he says, when you do your Christopher Walken, your personality improves. And I'm like, Dad, that's really insulting. That's very insulting. He's like, well, listen, I'm just telling you the truth. So
gotta
I will
love
leave
dads.
you with Christopher Walken.
Okay.
And then we'll get. And again, thank you for everything. I appreciate having the avenue to help people out.
Well, Con Nation,
and
thanks
as Chris
you.
would say, as Chris would say, you people out there with neuropathy or some other kind of disease, don't worry. More cowbell can help you get better. And go see my good friend, Dr. Bregman. He's the best. Take care. God bless.
Awesome. Thank you so much. Well,
everybody have a good night.
Yep.
And I appreciate everyone listening. And we'll talk soon.
Yep. Have a good night. Well, Con Nation.
Bye-bye.
Bye-bye. Well, not Con Nation. Thank you for tuning in with us tonight. I wasn't sure if I was going to have a show tomorrow night due to a medical procedure, but it's canceled. So let me see if I could whip up something for a topic for tomorrow night. One more thing I wanted to add too. So about the chronic pain patients and opiate issue, which, by the way, I'm using hashtag WE, W-E, capital W-E, capital R, and then one. We are one. And then also, I know there's one going around with U.S. Pain, which has been picked up. It's called Share Our Pain. And the other one I came up with a while ago was War Against Pain Patients. So hashtags, let's get those out there. Also, something that I was talking with Dr. Thomas Klein about is we should not put out any articles that have anything negative or that is against the chronic pain patients or this fight that we're having. This is a wildfire, and it's gotten out of control. And it's led by Clodney, but now, obviously, Trump last week picked it up, and they're going to be having a drug czar and stuff like that. So this is scary, and we need to do something immediately. We need to come together. I'm going to be honest. I thought this was going to be more organized and things were going to be together. I see a lot of little groups, but I do not see people working together. We need to put all of our egos aside. We need to put, whatever, if we don't agree on other stuff. But if we could come and agree on this and come together, that's what matters, really. Because if we don't, I just don't know what's going to happen. What? Okay. I don't know what you're saying. Something. Anyway. Oh, hi. Sorry. Oh, I guess I should talk to you guys. Sorry. Brian was telling me to look in the camera. But yeah, this is just such an important thing. I mean, people are dying. They're either dying because of suicide, because they have no lives. And look, who are we? Are we just a piece of meat? Are we nothing? That's not right. And we deserve to have a quality of life. And, I think, I think the problem is so a lot of people get the idea of that chronic pain patients are somebody that just kind of, just it happened and they took one or two pills or a few weeks of pills and now they're stuck. No, a lot of people have had this for years, just like me. I've had this for 23 years, which has grown and changed, and I've gotten more things. Lucky me, right? But this is how it is with every chronic pain patient I know. I'm not somebody that gets high off this stuff, and we need when doctors like cut you off suddenly, or say, I'm not going to have you at our office anymore for no reason at all. Like, I don't understand that. And if we do not start to come together and get organized, I mean, seriously, if we don't do that, I don't know what our future is. And, I mean, because doctors they're not even educated in, or they're not giving out alternative ways to work on chronic pain. Like, they're not my producer / assistant for Conspiracies Against Wellness, Thea Barnes, she lives in Canada, and like when they have chronic pain or something like that, she had CRPS. I think it was like a little bit under 2 years. They don't immediately just give you medicine. They do physio. And I mean, I'm talking about like 4 or 5 times a week. They do all these wonderful things. And I mean, like, I know we have to keep moving. I mean, that's something that I've learned. But the thing is like, the United States needs to do stuff for us too. I mean, they wanted to give everybody pills, and then now they're trying to pull that back. I just don't get it, I'm just really, really upset about this. And I think I'm just asking everybody that's in the chronic pain community, and actually not even that, parents, family members, loved ones, whatever. We need to come together. We need to start pulling together and having organization and working together and fighting this. Because seriously, if we don't, it's over with. I mean, getting a drug czar, that's not good for us, seriously. So that's my message for tonight. Sorry about the rant or whatever. Anyway, I hope you liked Dr. Peter Bregman. He was awesome. And I'm not sure what I'm going to do tomorrow night yet. I don't know. Maybe I might have a guest co-host. We'll see. So I just hope everybody has a great night and happy Halloween.
You've been listening to Conspiracies Against Wellness with Janelle Elgaway. Join us tomorrow at 8 p.m. Eastern to get in on the conversation. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG LLC, its employees or sponsors. I'm David Schick.
Copyright 2017 by EXG LLC. All rights reserved.